Good morning, this is the Misoprostol CPD talk for those of you who weren't able to attend the live talk back in November. Misoprostol is a really rare drug for paramedics to give, which means that oftentimes we sometimes overlook it in the early stages where we could give it and have the maximum effect. So it's really good to go over this and to make sure that we're up to date on when to give it and how to give it. Misoprostol is a basic mechanism of action. It is a sympathetic prostaglandin E1 agonist. So what this means is it turns on all the prostaglandin E1 receptors, which can be found in the uterus, bladder, and GI tract. And for the effect that we're interested in, it creates stronger and more frequent contractions of the uterus muscles. Now in JR Calc, we've got two indications of when we might give it. First one being either primary or secondary postpartum hemorrhage, or in the second case would be confirmed miscarriage or termination where there's excessive bleeding. Now for today, the main focus we'll be talking about is on the treatment of postpartum hemorrhaging. So there's several ways that we can define postpartum hemorrhaging. First one is whether it's primary or secondary, with a primary postpartum hemorrhage being considered more than 500 mils of blood loss plus clinical signs of shock within 24 hours following birth. This can then further be divided into either minor, major or massive bleeds, either 500 mils, a litre or 2 litres. And a secondary postpartum hemorrhage is where we got excessive PV bleeding less than 6 weeks post-birth. Now, this is not as defined as strictly, but JR Calc says roughly this should be a sanitary pad soaked within 30 minutes. So the causes of postpartum hemorrhaging, we've got the 4 T's. These can be trauma, tissue retention, thrombin, or tone. Now for us, 70% of the cases of postpartum hemorrhaging will be caused by this lack of uterus tone, where it's just not contracting down enough following birth. And this is really where misoprostol comes into the treatment. And misoprostol can also be used for treating tissue retention, but this normally occurs as a secondary PPH and is often associated with signs of infection. So the question comes, how do we estimate blood loss? If we're looking for whether it's 500 mils or more, how can we measure that? Well, we've got charts like this that kind of show us examples of what certain amounts of blood loss will look like. Or another useful tip is good to think of a measured bottle of liquid, and if you were to throw that around the room, how much mess that would make, and kind of compare the two. But all the studies that have come out suggest that we are absolutely awful at measuring blood loss. And this isn't just us, this is doctors and nurses also. With some reports saying that we're overestimating, some say that we're underestimating, and by quite significant amounts. Furthermore, this also doesn't account for any internal bleeding that may not be showing. So just because there is 100 or 200 mils of external blood loss doesn't mean that there is a significant more amount still retained inside. So we can also look at the clinical presentation, and I don't know if you guys have seen this table before, there's stages of shock, for what kind of obs we would expect to see for different amounts of blood loss. And these can roughly translate into minor, major and massive in stage 1, 2 and 4. But then we've got to also consider how these physiological parameters change in relation to pregnancy. As you're aware, in pregnancy, heart rate increases, respiratory increases, and blood pressure naturally drops. So then how will this affect how we are seeing these stages of shock? Well, in JR Calc, we've got this Prehospital maternity decision tool. If you haven't seen it before, it's really good to go have a look at it. And these give you sort of what the expected obs are and whether these would be green, amber, or red flags. And for just the respiratory, heart rate, and blood pressure, these are the numbers that sort of would come up. Now, these aren't too different from the previous stages of shock, with heart rate having a higher threshold and blood pressure as well. However, we still fall within this range of a minor bleed still probably presenting in that green flag section. So we might not necessarily see those signs of shock when the patients reach 500 mils of blood loss. So this is quite hard to actually be able to estimate when it is and shouldn't be administering misoprostol. So then the question come in, actually, should we be giving it prophylactically? What is this a harmless drug that we can give and there just be benefits for? Unfortunately, unlike as this case is with every drug, there are a list of harms. With common mild effects being shivering and chills, a lot of GI symptoms such as abdominal pain, nausea and vomiting, can cause headaches, breakthrough breathing, and hypothermia. Then we've got some moderate to severe harms, such as hypertension, tachycardia. Can cause, obviously, the uterine contractions, which we want, but that can be associated with pain, PV bleeding, fetal bradycardia and fetal death, which we shouldn't be experiencing because we would only be giving this postpartum, so once the baby's been born. And also some clotting disorders, myocardial infarctions, pulmonary embolisms, and other thrombosis. So this is by no means a harmless drug that we should be giving lightly. Just as an anecdotal case, someone I know who had to take misoprostol said although that this abdominal pain and vomiting is considered common and mild, this doesn't mean that it's any less unpleasant. This person said that when they were administered the misoprostol, the abdominal cramping was really severe, the vomiting was quite horrific, and for someone who is just given birth, if we don't need to give this and put them through that, then we should definitely not be giving this prophylactically, and really thinking, does this patient need it, while also trying to highlight, not giving it too late. So then we've got to consider what the effectiveness of this drug is. Now, currently there are no studies that have been published in the UK for the Ambulance Trust to sort of say how good this is compared to either no treatment or other treatments. However, the WHO did publish this meta-analysis back in 2018 where they looked at 12 randomized trials, including over 6,000 women, where they compared misoprostol with either a placebo or no treatment. 9 of these were in hospital, 3 of them out in the community, and there's a long list of different countries, from China, Egypt, India, Pakistan, to South Africa and Turkey. So the effects were in reducing blood loss of 500 mils or more, we saw about a 9.4% reduction, so really quite effective in reducing minor blood loss. If you on moderate blood loss, it's less effective. We got just below 1% reduction in reducing the moderate blood loss. In terms of reducing maternal death, there was no reduction. So what this kind of says to me is that misoprostol is good at reducing blood loss. However, it is not a standalone treatment. If we've got a patient suffering from a PPH, we shouldn't be giving misoprostol and thinking that's the job done, that's going to solve it. These patients, especially the ones bleeding a lot, will require rapid transport to hospital and further interventions. The misoprostol just helps on top of that. It's also worth noting that this study was published back in 2018. So although it is still relatively recent, it is creeping up to being at that 10-year-old mark, and whether sort of more evidence has come out since then, or if it's still relevant, we're not sure. As I said previously, there's no UK or ambulance service-based studies involved in this, and a lot of these studies did use different doses and routes of administration used. So although this gives us a rough idea of that this how effective this is, it is not completely comparable to the patients and settings that we're giving this in. So where does misoprostol come into with our treatment priorities? When are we going to give this in our sequence of management? So first thing we need to be doing with the patient with their bleeding is administering high flow oxygen, and then titrating that down to reach the 94 to 98%. Then provide uterine massage, where we try and get the uterus to contract by itself. Provide any external pressure, direct pressure to any external tears. And then we give the Utertronics, that's the misoprostol. We'll then look at getting large bore access, preferably bilaterally and with a big gauge cannula. We don't want to be messing around with any blues or pinks. Administering TXA at this point, and then considering fluids. I should add in all this as well, our priority is also getting this patient to hospital quickly. We don't want to be messing around on scene for too long as these patients are bleeding out. We want to be doing all this quickly, systematically, while moving as much as we can. Something else to consider that can often be overlooked is skin-to-skin contact with the baby. A lot of the times if we've got the mother who's not very well and crashing, and also we've got a baby to deal with, we want to we often separate them and treat them individually. But actually providing that skin-to-skin contact helps both the baby and the mother, and particularly it helps the mother uterus contract, prevents this lack of tone, and has been shown to decrease the blood loss and use of misoprostol and other uterotonic drugs. So as much as we can, we want to get baby on skin-to-skin contact with mum, because that could be seen as part of the treatment for the PPH. That is going to help as well. Now, as with most JCALC guidelines, written all over it, it says about seeking senior clinical support if we don't know what to do. And this is always great, except they never specify who it is that we need to speak to. So just a few considerations for working in SAS in Scotland. There are no pre-hospital obstetrics teams in Scotland. So when it comes to seeking clinical advice or trying to get back up, we're not going to get a pre-hospital obstetrics team out to help us. And on top of that, the Trust is unable to request the attendance of any community midwives. So when it comes to getting anyone out to scene for us, that's not going to happen. Unless the community wife is already in attendance, this is going to be paramedic-led. Obviously, we have a clinical support desk, trauma desk, and we can contact the maternity unit for advice. However, what that advice is going to be is most likely rapid transport to hospital. So I think it's really useful to learn about what trauma teams and critical care teams are available in your area, and talk to them and find out what their scope of practice is in regards to obstetrics treatment, so that we're not waiting around on scene or requesting resources that aren't going to bring anything more than what we can already give, and just being confident in that sequence of treatment priorities and doing them while en route to hospital. So as for presentation, misoprostol comes in 200 microgram tablets. There's one dose that we need to remember, which is 800 micrograms, which is 4 tablets. There is no repeat dose. And although this is an adult dose, if the patient is under 18 years of age, we still treat them with that adult dose. So that's it, 800 micrograms for everyone. As for the route, there are 4 potential routes, which can either be oral, sublingual, vaginal, or rectal. But JCALC only allows us to give it either sublingually or rectally. Now, the onset of action time, as you can see here, varies quite significantly, with sublingual 11 minutes, rectal being up to 100 minutes, and the rectal only being indicated for if there is an airway concern. And the duration of action is pretty standard, between 3 to 4 hours there. So hopefully the patient will be in the hospital by the time this wearing off and can receive other drugs. I have put the question to JR Calc as to why we are advocating to give the rectal route and not the vaginal route, given the onset of action time, and I'm still waiting for a response back. But the thing to take away from this is, the first route is always sublingual, and then if there's an airway concern, we can go rectal, but the rectal route does have an extended onset of action. So as much as we can, we want to be giving this sublingually. So how would this compare to how do we give this if other uterotonics have been given? There's two others, which can be oxytocin or synthometrin. And if ever we're in a circumstance where a midwife has given either of those, where do we stand giving more misoprostol? We're absolutely able to give more if the first one isn't been effective. Synthometrin is the preferred one. However, due to cost and storage issues, misoprostol is deemed as a suitable alternative for the ambulance service. And JR Calc does allow for all three to be given in quick session in the case of a catastrophic hemorrhage. So in regards to where does our treatment with misoprostol fit in with all the others, there's no concern. If it's a big bleed, we can give it on top of all these other uterotonic drugs. So finally, we'll just go through the contraindications. If there's any reason to suspect that there is another fetus in the uterus, we do not administer uterotonics. As I said previously, one of the harms is that it can cause fetal bradycardia and potential fetal death. So we do not want to be giving it if there's a fetus still in situ. We've got to be really careful with potential multiple pregnancies. I should stress, though, this does not apply to the placenta delivery. It used to be the case that we had to wait until the placenta was delivered to give misoprostol. That is no longer true. So once the baby is out, if there is bleeding, we can give misoprostol. We don't have to worry about the placenta. And obviously, no anaphylaxis to misoprostol or any other component in the product, or to other prostaglandins. I've never come across a patient who is allergic to these, but if they're specifically telling you that they are allergic and they have an anaphylactic reaction, we shouldn't be giving this. Also, thank you for listening to this. If you have any questions, feel free to put a comment on or to email me directly.